Yeah, so this a little change. So till we get our other cases ready, this will be case number 8, if you can see that. It's an 87-year-old female. So myself, Dr. Kinney, who is a director of the lab, I have Dr. Huda, who is assistant director for the fellowship program, but is an associate for us, helping both in coronary as well as structural cases. And I have Lori Croft. Can you see her?
Dr. Croft, director of the Echo Lab, and let me invite.
John, please, John, come here.
Let me invite Dr. Dominguez, Chakravarti, Goel, Jane, Little, and Mac to stay in the panel if they so wish.
Yeah, so she is the director for the non-invasive lab here. She will be the one helping us with this case. So go back to the slides. So 87-year-old female who has had progressive exertional dyspnea for years, and you will see that she has had few procedures with iron syncopal episode. So if you use AFib on Eliquis, and what she has had was a severe mitral MR at once, and that time before the clip, the reason for she had septal ablation, and at that time after the septal ablation she required a pacemaker, got better for a while but then continued to have symptoms. Then she did have a TRO, so that was 2023. So the original septal ablation was in 2020. So she was okay for a few years, and then after that she had a clip, was again okay for a little while, and now she continues to have symptoms. So only medication that she can tolerate is beta blocker. So all the other medications has been tried but not able to tolerate. So we're going to show the echocardiogram that they've had, but what we see that she has concentric LVH. So base is not especially thick, but overall we are getting between 14 to 15. Now, when she had a septal ablation in 2020, the septal wall at that time was about 15 millimeters, and she had a gradient of about 50 mid-cavitary, and post-PVC was about 120 or so. So everything got better at that time. After the ablation, she went down to about 50 on medication, was better. After a clip, she got better. Now again, symptoms got worse. So Lori, if you can show the echo now.
Symptom? Which symptom that is? Short of breath or chest pains or what?
Yeah. Dyspnea, unable, decreased exercise tolerance and dyspnea, which is likely diastolic dysfunction that she's having with this thick LV. Yeah, Lori.
George, can I ask a question?
Anytime.
The statement was that the MitraClip caused an LVOT gradient of 61. MitraClip should be fixing the LVOT gradient. How do you explain that?
I'm not sure it said it caused, but it just was just the evolution of the disease. Huh?
It said caused.
It said caused? I didn't see that. Was it a cause? I don't think that's a cause of the. It's just association, or it just happened to happen.
Well, I mean, if anything, MitraClip should improve the.
That's right. It pulls it away, from the septum. You're right about that. Avoids the sound.
Okay, Lori, they're asking that.
Okay, so with your original alcohol septal ablation, who has had a gradient just from the septum because she has a small one with a small LVOT. There was no SAM, and it was like mild to moderate or maybe moderate MR, but there wasn't a lot of SAM. It was just from the outflow obstruction of the septum bulging into the LVOT. So she underwent that alcohol septal ablation, and then because of the progressive MR, underwent the clip, which had nothing really to do with the first alcohol septal ablation.
Can you show the mitral valve? So
this is,
let me show you.
so this is the 5-chamber view.
Yeah.
Right.
This is mobile turbulence in the LVOT. Here you can see, in the 3-chamber view, you can see how that mitral clip starts to move into the LVOT against the septum there. And then here is the gradient that we're getting now. We're getting a 78 millimeter gradient, an Elliot's mercury gradient at rest.
Well, I can't imagine what it would be without the mitral clip. The mitral clip would have been, without the mitral clip would be obliteration.
Now, what she feels is that the clip actually right now, go back to that echo. You see that the way the clip is moving, that it is...
it's touching the obstructing it.
Lori?
Right. And in the literature, this is obviously acutely, this can happen post-clip, or sometimes it can happen, and they plan for that pre-clip by looking at the neo LVOT
Right.
planning ahead.
Yeah.
So this happened post-clip and a little while post-clip. So that's why we're here doing the septal ablation.
So the what?
So what was the time of the clip? Let us understand that. What was the day of the clip? And 1 month ago, or 3 months ago, what is it?
No, it was 2023.
2023, so like a long time ago. So it's not really a consequence. Okay, we got it.
No,
We got it.
no
Okay.
consequence.
Okay. Is it clear now to the panel?
Yeah. You know, the case is complex, so got to go step by step in order to have a pretty regimented approach and understanding. But the echo is very diagnostic, though, no?
Can we just ask you a little about medical therapy? I mean, has she been maximized on beta blocker EF still like 80%?
Well, what we heard was that the beta blocker was the only medication that she could tolerate. So there's at least at this time. So there is a situation with ability to tolerate, which is not bradycardia because she already has a pacemaker.
And
So-
Captain?
No, now would I know?
Quantum could not approved by the insurance.
Like which one? Oh, Mavacaptan.
Yeah. It's interesting because I
Not
feel
an
like
easy drug to get approved, yes. Now let's go back to the angiogram. Any other questions from the panel?
Well, it looks like the clip obstructs the septal, your target septal right now. So I don't know if that the way. That's good.
Yeah.
The clip
what
show
we
us a
say is
septal.
This is, yeah, not that a classical, HOCM where you see a basal septal hypertrophy, but she definitely has thick septum, 14 to 15 millimeter concentric. Then the question now is, could we help this person by doing another, septal ablation? So many times what happens, we've done one septal ablation and rarely do patient come back. About between 50-20% of the patient come back. The question is, why do they come back? And one of the reason we always believe that, I know you occluded that a branch of the septal, is there a collateral that has come from a different artery, usually from the right coronary artery. So that's why you see here, there's no collateral here. And this is where we were last time. So not the small first septal, the second large septal which fans, and then you have a first branch that comes off. That's where we were, and we occluded that, and it was completely gone. But if you see now, you see that septum is back, septal artery is back.
So Dr. Kennedy says, once in a while we bring these patients back. She's an amazing operator, and we're very careful to try to avoid taking these patients go into complete heart block. So we maybe are a little less aggressive and tell them that they may need to come back so that we don't end up putting a pacemaker in them.
Yeah, well, that's no longer the story here. He already has a pacemaker. So,
I know, but-
yeah, what on the bridge here? But what is very fascinating is that I wonder, could the position of the mitral clip or seeing the mitral clip next to the coronary angiogram can help us understand the target septal? Because for once, we have a marker about exactly what area of the mitral valve approaches a septum. Therefore, we know roughly which area of the septum is the target. That's a unique marker. And I think we see that it is exactly at the second septal. I think that's a very interesting marker.
We also use, we're going to use the echo contrast to really zero in on where that septals up.
Oh, I'm sure you do, but I'm sure you do that because we don't have the mitral clip in every case. But here we can see that, and I think very, very dramatically can see that right now. You put the wire at exactly where the mitral clip is.
Now, if you don't mind, I just joined here. We wanted to show the slide, which we make it in terms of timeline. There was some question.
Yes.
Show the slide, please.
Yeah, there was.
So that
Yes.
everybody understand everything. Go to the, See this now? This is this case. Was not shown earlier, but basically the 2019 to 2024
Oh, that's nice.
gradient. Then patient had a septal ablation. You can see there, septal thickness. And then June 2020 has a septal immediate improvement. Septal thickness become thinner, gradual increase. The TR was done in 1223, and then now increase in the gradient. That's where it is. EF did decrease slightly, but remain still about 57%.
And now we're getting a 77 millimeter gradient.
Yeah.
Any comment of any comment from the panel regarding the thickness here? That's a little bit on the border zone, even from the beginning. Interestingly, I think we do see that in some women.
1.4.
Very reactive. Very reactive septum sometimes in women, smaller size, perhaps overall harder. Maybe that may be, otherwise perhaps in a bigger size, but that may be a little bit under the.
The question I had was actually about the M tier. I mean, because the septal thickness 1.3, but yes, hypertrophic cardiomyopathy with obstruction can certainly have an abnormal mitral valve with long leaflets. But I would wonder just how long that posterior leaflet was, because if you've truly got a good bite with an XTW and you stuff 12 millimeters into a posterior leaflet, it should be pulling it out of the LVOT, not even allowing it. So I'm just curious, has there been some slippage, some partial SLDA? What's the mitral clip evaluation doing? Or was that even considered as perhaps a second clip or a modification of the mitral clip to pull it out of there?
But is there any MR
Just
now?
go live audio. Let's show you the mitral. It's mild to minimal MR now. The clip is functioning well.
Okay.
No SLDA.
Yeah, we actually, the earlier echoes also had been shown that the regurgitation was 1+ at the baseline, 1.5 years, just about 1 year ago, and remains same 1+ only. It's case.
We anticipated all these questions. We have some.
Very good. That's why we're asking them.
Yes.
Yeah. Yep.
Yeah.
No, mitral, you have the MR, or we can go live, show it. The other thing is, if I go show the angiogram, so this is the patient already. So why we are very careful with selecting the septal? Okay, that's the key about septal ablation, that you have to go to the right septal, the first septal or the branch of the major septal. So that is why first time, so the second septal is a major septal and there's a branch that comes and go into the base. That is what we need to go. And then we give the definity, we'll confirm it with the echo, and then give the alcohol. Now, why we do that? To avoid pacemaker. This patient already has a pacemaker, so we are thinking, because this is the second time the person is coming and then we already have a pacemaker, can we just take care of that entire septum? I mean, it would be a little bit large MI and the risk of.
But that's okay. Her ejection fraction is good, and clearly serial echoes have clearly shown her problem is now increasing LVOT gradient.
Yeah, that looks good. Yeah, MR, you put color. You can see that.
No, we don't see the echo. We see the old echo.
Yeah.
There you go.
Now,
Yeah.
this is the
Yeah.
Most of
Yeah.
aliens, you see it at the LVOT and just mild minimal clip. I mean,
Yeah.
sorry, MR.
MR. Yeah.
Clip looks very good. Yeah.
Good.
Yeah,
Let's go where the money is. Money is in the septum, not in the clip today.
So I'm not going to go to the branch. Let's go to the.
Let's go to the main then. Yeah. So apparently, let me just clarify. This septal had like 2-3 branches before. Dr. Kinney had ablated the branch like all the way to the left as we see the screen. But there are a couple of branches towards the right. And now instead of selecting a branch, it's going to go to the main stem of that septal and ablate entirely. Because patient already has a pacemaker, so that you understand. If we play back the angiogram before again, you're going to see exactly what it is. And this correlates exactly where this SAM occurs. That's pretty obvious.
They are very important. Go. Good. Okay. I will situate it. Then what we'll do is, I want to make sure there is, give me.
Definitely.
So what you do is, since we are going to inject anything, you have to remove the wire underwater. Can we show here?
Yes.
Underwater.
See, they're seeing it, yeah. So there's no air.
Show the ceiling camera.
Yeah, we see that. Yeah, we see that very clearly.
Ceiling camera, okay.
Okay, now let us give you definitely. No, which one?
It's in the night.
You need to do the definity now?
Yeah, see, doing it. Ready?
Go back and show live.
Live echo.
Well, let's see it better. Let's see, high quality echo. Wait a second, don't inject.
Okay.
Oh, now it's good.
Okay, do I go?
Or what happened now?
You can inject.
No, you
Or in the
can't.
contrast package. See it there? Contrast
No,
settings.
we can't see get a better image.
yeah,
Huh?
yeah. They've put on contrast settings, so that's why You lost the 2D image.
Yeah, there's something. Right. This is better. This is better.
Can see it. And it'll be harder to see, like, yeah.
Okay.
All right, what is it?
I think we are in the right septum.
Yeah.
You see it? Base of the septum, right there.
Yeah.
See it? Yeah. Okay. Now what I do is, your office, I'm going to go fluoro.
So once you identify that,
And then I'm going to take a cine because we are very proximal. So
but you have to go off the clip a little bit, because the clip is overlying a lot of arity.
No, it's okay. No problem.
Yeah.
go. Yeah.
It's good.
Also, you see there's no dye getting into the septum, so that's good.
Yeah.
Great.
So you got, I mean,
It's alcohol.
this maneuver is to make sure that somehow the balloon hasn't inadvertently pulled out of the septal while you are removing the wire. So sometimes it happens because the vessel may straighten or something, and the balloon may move a little bit. And then in that case, you may be injecting the alcohol partially in the septal and partially in the LAD, causing perhaps a bigger MI, which is not the case here. So that's a kind of a safety picture.
So very slow injection.
But we don't see that. Can the camera please show the injection or something? We're seeing,
Fluoro. Yeah.
we're seeing something on the left side that is.
Of your injection.
Can you make the hemodynamics very big at the top left, please? Top left is not used well. The window, top left window.
If we don't need the echo now, you can make a hemodynamics good on the left side.
Yeah, make hemodynamic side big.
And another point which I want to make, that what will be the response when you inflate the balloon, which is always there for 2-3 minutes, you start seeing some decrease in the gradient. That means you'll have a good response.
Yeah.
And if you don't see any decrease in the gradient that 1-2 minutes, then always a trouble.
You see the post PVC gradient is already down.
Yeah, it used to be 100 plus. Now it's about, I mean, it's a lot, but it's about 50, 60.
So it's over a minute. I've given the 0.5 cc.
Yeah. You remember how much it was given the first time?
2 cc.
2 cc's.
2 cc. Okay, well.
In a small branch, I would give 3 cc's now.
Yeah, there you go. You got to give at least 2.
Yeah. Yep. But not all that patient got used to it. She got 2 cc's before. Now you have to increase it a little
Yeah,
bit.
that's what I'm saying. Exactly.
Yeah.
Look at the post PVC. Almost only
This,
about,
2.5 maybe.
yes.
Give it full 3.
Very good. Any further comments regarding the procedure? Dr. Gall, how simple or not simple is this procedure for interventionalists who maybe does some corneal experience, but obviously it has nothing to do with TAVR, but how easy or not easy this is. What should we pay attention?
It's definitely challenging. It's not routine coronary because you like to open the arteries, not close them. So it's definitely challenging. However, Dr. Kinney has been doing it for many years, and I'm trained by her, so I have full faith in her expertise. However, knowing that she has septal ablation done 2 years ago, and now she again has this thickness of the wall, and she has high gradients, I'm hoping that she get a good result, and then she can get more years out. Good thing is now they're injecting the dye, injecting the alcohol more proximally, so they're going to have more ablation. And knowing that she has pacemaker, I think it's probably will help the patient a lot.
Yeah, definitely having the pacemaker, alleviate some of the safety concerns. Of course, having a pacemaker.
Post PVC.
Yeah, post PVC is now less than 40. Less than 40, the post PVC gradient. For
So if we are
120,
less than half the successful procedure.
Maybe we can get the mavacamten approved now.
After the procedure.
Yeah, post procedure.
So
Tell
now
the
what
insurance
we do is,
company it costs more.
So it's 3 minutes, 30 seconds. We are given 3 cc. And now what I'll also do is there will be alcohol in the balloon catheter shaft. So just inject some saline and also let it flush down. So maybe another few minutes of the balloon inflated. And I've kept checking the LED multiple times to make sure the balloon is there.
Yeah, that's
Very
well,
rarely.
well, that's another situation that can happen. As you're injecting, you may inject forcefully, and somehow the distal vessel can't accommodate the volume. And again, this balloon is small, it's slippery. It may just be pushed back just by your injection. You're injecting too fast, and then balloon can come out, and then you keep injecting without checking. You may be injecting in the LAD. So that's continuously. You have to be certain you inject very slowly, and that you keep checking.
Yeah. And actually, last time she had a good relief for 4 years and 3 months. To get another 5-7 years will be good. Now, knowing that we got you more MI.
So any other questions regarding this procedure?
Let's flush everything and come out and let's take a good gradient.
Yes, we have to treat.
Now we have to flush everything. Now remember, re-zero and all. It will be, I think, low will be less than 10-20. And you see always that because now patient having MI, see the diastolic pressure going up now. And diastolic.
Yeah.
Because clearly sluggish. How is the EF point of view, Laurie?
It looks the same. It's fine. The substance looks a little sluggish. We're not getting any gradient on red.
Yeah, that's what I'm saying. Let's flush it. It will not be any gradient now.
Okay.
Go negative and come. Yeah. So let's flush both and there will be very little gradient.
Yes, take picture of the LAD, so we'll complete the coronary part, and then we'll do the hemodynamics.
Hafiz.
Very good.
Okay, yeah.
Well done. Yeah. Look at that.
Look at the baseline gradient.
Keep that again, please, main screen.
You please, big the hemodynamics, big. Yeah, thank you.
Look at that. Look at that. Didn't I say? All will be by fine.
Yes, sir.
Echo said it first.
Plastic. Yeah. Yeah.
There's no post PVC either.
Yeah. No.
Oh, bye-bye septum.
Yeah, that's okay. We wanted that.
And the flow in the LED is less. Give me some vasodilator. So I get some.
So remember what happened is there will be some decreased flow because the edema has created now that MI. So you need to give some vasodilators and so on and so forth, which is not an issue. But look at the gradient is gone. But this is not uncommon because of the local edema that you have a little decreased flow in that LED. So pressure is good.
I give some more verapamil.
Yeah.
Okay.
Give a little more time.
Remember, these patients have usually go to the ICU if they don't have pacemakers in because they can have heart block up to 48 hours past alcohol septal ablation.
Absolutely. She actually had that.
I know.
She developed the very important. We actually had a patient, two patients over the many years that would develop heart block after septal ablation in 48 hours. So we made a policy that we put a temporary pacemaker. This patient, because of that, was diagnosed, did not have heart block last time, second day, developed third day. And that's why required the pacemaker at that time.
Yeah, and Laurie, what is the experience with what the surveillance timing for a possible VSD?
So when we do a general echo maybe 48 hours post. We don't actually check the gradients because sometimes it'll go up because the edema resolves, and then once it goes into total infarct, it'll come back down. But we check quickly across the color, across the interventricular septum, and for pericardial effusion. It's a very limited echo.
Yeah. So just to say that we do about 12 septal ablations per year, and we actually haven't had any patient with a VSD. We did have one case with the refractory the VTAC, and we lost that patient, and that patient's septal thickness was 29 millimeter, but that patient had a liver cirrhosis. There was no other option. So that's the only complication we had, but no VSD in our, we have been doing it since 2002 when Spencer, we brought the Spencer here. We started with the first program and had done tremendously well, about 400 or 500 cases now.
Dr. Kinney and Dr. Sharma pick appropriate patients. You know, this is for people with comorbidities with not over like a 2 millimeter septum. Usually we do it around 2 or less, between 1.5 and 2 that have outflow gradient. They usually are older, basal septal hypertrophy. It's not the typical hypertrophic cardiomyopathy that has like a 2.5 to 3 millimeter young person.
Good. Now, but George, you have any other lectures left? We have one case will be ready shortly. But it's ready. But no, but the
Michael?
lectures are. You still have to do 1 or 2 lectures there.
Yeah, we have Dr. Mack is going to do a lecture, and then after that lecture we go to the live case. How do you want to do?
Okay, just give 1 second. Continue some discussion by our faculty about the septal ablation.
So, Michael, here with the just and others actually, with this kind of level of septal thickness that we see here, might not really be even considered in any place for a surgical myomectomy. Am I wrong in saying that? This is sort of a borderline case, but in my mind, there are many women who fall below the 1.5 thickness.
No, I totally agree with you, George. And, the other thing is, with mavacamten, we've seen both surgical and alcohol septal ablations decrease dramatically. It really works.
Yeah, that's been our experience. Also, we would do maybe about one alcohol septal ablation every couple of weeks. Yeah. And once mavacamten got approved, I can't remember the last time we've done one. I mean, it's just an incredible medicine. Of the 600 patients we have with HCM in our clinic, we've got about, a third that are on mavacamten, and really only one that had a little bit of mild LV dysfunction, but for the most part, it's been very well tolerated.
What's your experience with patients who are highly symptomatic? They have high gradients. Would you consider synergistic? Would you do a septal ablation and then start the patient on mavacamten just to give them symptomatic benefit, because you know that they're going to have gradient back maybe in like a year or 2 years or 3 years down the line? Would you start mavacamten at the same time, just do the septal ablation for acute, if they have let's say syncopized or they have very high gradients, they are limited in day-to-day activities, before you have the mavacamten effect taken for a few months?
Yeah, I mean, I'm not the director of our HCM clinic. I'm not aware of us doing it. We will do these septal wall thicknesses of 1.4, 1.5 is those patients that have mitral valve disease, and we'll do the preemptive alcohol septal ablation to increase their neo-LVOT for TMVR. And that's actually where we end up doing them in this kind of wall thickness.
I don't run the HCM clinic, but my understanding is from the guidelines, they're equivalent first steps, surgery or alcohol septal ablation or mavacamten, but not simultaneous steps.
And we haven't found it necessary to do that as a bridge to mavacamten effect.